Good afternoon. Thank you, Mr. Chairman. The use of anatomic-specific proximal femoral allografts in revision hip arthroplasty is limited. Between 1988 and 2000, 49 revision hip arthroplasties using anatomic-specific proximal femoral allograft longer than 5 centimeters were performed. The patient's mean age at the time of surgery was 63 years. The reason for revision was aseptic failure in 39 hips and septic loosening in 10. In all cases, the operation was performed for infection. The procedure was staged. The femoral defects were classified according to the system proposed by the American Academy of Orthopedic Surgeons Committee on the Hip. 37 hips were classified as type 1 defects, 10 as type 3 defects, and 2 as type 6 defects. The defects were further classified as level 1 in 14 cases, level 2 in 19, and level 3 in 16. All cases were graded as severe. All allografts were provided by the Queensland Bone Bank, which complies with all standards of the Musculoskeletal Council of the American Association of Tissue Banks and the Code of Good Manufacturing of the TGA in Australia. All allografts were frozen and sterilized by gamma irradiation. Now, regarding the technique, the preoperative radiographs were inspected, and according to findings, revision instruments, implants, and allografts were prepared. The first stage of the operation included removal of the failed femoral component, cement material if was present, and debridement of all fibrotic tissues and membranes. At this stage, the allograft is brought into the operating room and samples are taken for bacteriological culture, and then the allograft is immersed in betadine solution. A trochanteric osteotomy was performed in 38 hips. In 9 where a calcar reconstruction was performed, it was not needed, and in 2 where the deficiency affected the greater trochanter, it could not be performed. The trochanter is fixed with a cable grip system, and now we prefer the sliding osteotomy for its stability. At the junction, we prefer the step cut of the osteotomy for its rotational stability and increased contact surface. And again, in the calcar reconstruction cases, a transverse or oblique osteotomy was sufficient. The allograft is prepared on a separate table, and after the appropriate length is judged, the femoral head is removed, and the distal end is shaped to fit the host step cut. The allograft is rimmed and broached to achieve an appropriate fit of the implant, and the host femur is rimmed to the appropriate size. The implant is cemented only into the allograft, and the allo implant composite is then inserted into the femur before curing of the cement, and care is taken to prevent cement from penetrating the host allograft step cut junction. In the case of a calcar reconstruction, the implant was inserted first into the femur in the usual manner, and then the allograft is fitted to its place. The allograft is secured to the host femur with cable wires. The mean length of the allograft was 10.4 centimeters. The mean length of follow-up was 10.4 years. The mean Harris hips improvement was 34 points, and all patients improved by more than 20 points. By our definition, 75.5% of the cases had a successful outcome. The Kaplan-Meier survivorship analysis predicted 83% rate of survival at 17 years. At the last radiographic review, the junctional union rate was 90%. Graft resorption was observed in 4 hips. In all it was periosteal, and in all it was graded as moderate. In 3 of the hips, the resorption was confined to area around cable sites. There were no signs of definite loosening of any of the implants. 6 hips were re-revised for a failure rate of 12%. 4 hips were re-revised for junctional non-union and aseptic failure. 1 hip was re-revised for host step cut fracture, and 1 underwent resection arthroplasty for recurrent infection. 6 other operative procedures were necessary. In 3 cases, a reattachment of the greater trochanter for trochanteric escape was performed. In one case, after a postoperative whole step cut fracture, the fracture was underwent open reduction and internal fixation using tibial struts allograft. One case with resorption of the allograft underwent augmentation with tibial struts allograft, and one patient underwent exchange of the tibial of the acetabular liner and femoral head for recurrent dislocations. We conclude that the results of the study support the use of large structural femoral allografts in complicated case of revision hip arthroplasty presenting with severe loss of femoral bone, where standard revision methods are not an option. Thank you.